So we're going to move on to vasculitis. And obviously this is an area that you're going to be examined about. And what we're going to try and do is highlight those vasculitic syndromes that I think are easy to tease out one from the other. Okay. So when you think of vasculitis, I'm going to classify vasculitis into large vessel, medium vessel, and small vessel vasculitis. And under the large vessel vasculitis group, we have giant cell arteritis and temporal arteritis. We no longer call temporal arteritis. Temporal arteritis, we just prefer the word giant cell, and we'll come back to that in a second. And then Takayasu. Those are the two classic forms of a large vessel vasculitis. When you think about large vessel vasculitis, then the most common one of which is giant cell arteritis. And when you think about giant cell arteritis, you need to understand that there's a very strong relationship between polymyalgia rheumatica and giant cell arteritis. And the group at Mayo argues that essentially they're the same disease, but opposite ends of a spectrum. So before I start going into vasculitic syndromes in great detail, then I just want to talk a bit about polymyalgia rheumatica, but you need to understand that probably the syndrome that we call polymyalgia rheumatica is really just a manifestation of giant cell arteritis that isn't really blood vessel related. Does everybody understand that point? So, who would you diagnose with someone with polymyalgia rheumatica? It is a woman closer to the age of 60 who is pretty Caucasian, meaning that it is it's quite infrequent in blacks. And amongst whites, it tends to be very even Scandinavian driven, which is why in areas around the Mayo Clinic, you've got such a fantastic opportunity to actually study these diseases, specifically polymyalgia. So very Nordic in extract in terms of as you look at the patient. But they're never under the age of 50. No board question will have a patient close to 50. They'll be 60, closer to 70. So a Caucasian woman close to 70 who has non-specific symptoms of aching in her shoulder and hip area. She's not weak. She's not tender. She aches in her shoulder girdle and in her pelvic girdle area. She has a very high SED rate, closer to 100, and a phenomenal response to 15 milligrams of prednisone, an absolute almost response. The next day she's going to call you and say, I am dramatically improved. Those are the symptoms of polymyalgia rheumatica. I guarantee a board-related question. But if we go back to this, we've got this concern about patient presents to you with polymyalgia rheumatica. What % of them go on to develop giant cell arteritis and get a headache? It's a relatively low %, and it depends on the studies that are done. Perhaps 20, perhaps 15, perhaps 30. We don't know for sure. Okay, so everybody understands what polymyalgia rheumatica is. Here's the other thing to teach you. The huge majority of patients with a diagnosis of polymyalgia rheumatica that you put on 15 milligrams of prednisone are off prednisone after 2 years. It is very rare to still be sitting with the right diagnosis. So if you've got a board question and they're still inferring that the patient is on prednisone 2 or 3 years down the line for a presumed diagnosis of polymyalgia rheumatica, there's something wrong. Either the patient is being incorrectly treated or the diagnosis is just wrong. So prick up your ears for that. Meaning, stated another way, that your patient with polymyalgia rheumatica is usually off steroids by 18 months to 2 years, and someone who's still on that drug, the diagnosis is wrong or just being overly treated. There is a differential diagnosis for patients with polymyalgia rheumatica, and I give it to you: viral myalgias, rheumatoid. About 5% of patients with rheumatoid arthritis actually present in a polymyalgia-like manner. And it's only a year or two down the line that you recognize they're really not polymyalgia, they're really rheumatoids. And I've given you another differential. So prednisone 15 milligrams starting off dose, and then you taper them down. Sometimes you have to add methotrexate, and again, every patient gets a bisphosphonate or even Forteo depending upon the indication. Now, let's go to the pure vasculitides. And I think the size of the vessel helps us so much as we look at trying to classify and trying to put a patient in a category that you can understand and treat, particularly from a board-type perspective. And these questions are almost always asked on boards. And vasculitis is just a heterogeneous group of blood vessel disorders characterized by inflammation of blood vessel. But what's really key is the size of the vessel that's involved. Because when you think about it, a blood vessel really doesn't have much that it can do. It can either, if it's a big vessel or medium vessel, let's say, for example, if it clots up or has an aneurysm, there'd be pretty lethal consequences. But if it's a small blood vessel, like in the skin, you're just going to see a rash. So there's a patient with a vasculitic rash. If you have a look at this lesion below, that's relatively old, and I wouldn't biopsy that one, but the lesion above, that looks young and fresh, and that's the one I would biopsy. Here's another patient with a rash, and you just look at this patient and say, okay, they have a lower extremity vasculitic-looking rash, but I can't tell you what this is for sure. I'd have a differential diagnosis, which would include Hinoch-Schönlein purpura, or it would include a cryoglobulinemic vasculitis, but this could be just a simple, plain leukocytoclastic vasculitis. So we're going to talk about that. On the other hand, if you've got a blood vessel here, as you can see, here's a medium-sized blood vessel. If that blood vessel is involved, and if you get cutting off of blood supply at that sort of a level, there's going to be enormous consequences, and we're going to talk about those. So what's the incidence of vasculitis? Very difficult to tell because we argue all the time as to how to classify these different syndromes. It's really hard to give you an epidemiology. The only one that we can really say is that, Kawasaki occurs in kids, and that's the vasculitis that you're going to see almost exclusively in kids. But think about a blood vessel. It has a very limited response in terms of what it can do. It can increase your permeability, and you can get escaping of red cells and white cells, and therefore a rash. Or it can weaken and give you an aneurysm and a hemorrhage, and if that happens in a medium blood vessel in the brain, get a subarachnoid hemorrhage and something pretty potentially lethal. So, before we get to actual vasculitis, you've always got to be aware of the fact that there are several disease processes that mimic vasculitis. And we've spoken about infective endocarditis before. It certainly can. Streptococcal infections, DICs, atrial myxomas are the classic cause of a pseudovasculitic syndrome. Amyloid, cholesterol emboli, you know the clinical situation for cholesterol emboli. Drug abuse, for example, cocaine can mimic CNS vasculitis, even give you a vasculitic type picture of the heart, and that's how you get some of the conditions that are so lethal with cocaine. Okay. Here's an important slide. And I think in the next 10 minutes, everything that we're going to talk about starts off here. So, I mentioned large vessel vasculitis, and we spoke about giant cell arteritis. Takayasu, those are the two major large vessel vasculitides. On the other end of the equation, the small vessel vasculitides, for example, leukocytoclastic vasculitis, Hinoch-Schönlein purpura, cryoglobulinemia. And stuck in the middle are the classic syndromes that you're going to be asked about. So let's go through these classic syndromes. Let's start off with large vessel vasculitides. Takayasu's, young woman. In our country, more common of African American background, much more common in the Far East than it is in our country. Japanese woman. And if any of you want to go get yourself to a conference in Japan, then just do a study in Takayasu's and you'll be invited. It's a chronic vasculitis of the aorta and its large branches. It affects different organs. Sometimes pulmonary vasculature is affected, coronary vasculature, but it's a disease of young women which seldom occurs after the age of 40. Now, the American College of Rheumatology put out a classification system which I don't really care for, other than that it reminds you what this disease is. Women younger than age of 40 who have claudication of their extremities, decreased brachial pulses or pressures, blood pressure differences, bruits, and an arteriogram that's obviously abnormal. The tragedy of this disease is that patients present in this pre-pulseless phase where they have pulses, but they complain of fever or night sweats or joint pain or muscle pain, and they have a high SED rate, and we have absolutely no idea what's wrong with them, and then, oh my gosh, they present with the claudication, the headaches, the dizziness, the amaurosis, the difficulty in looking up, renovascular hypertension, cardiac with chest pain, pulmonary with dyspnea, GI with anorexia and nausea, and then very rarely rashes. But I think it's pretty obvious to you that what's critical is the blood vessel that's involved. The common carotid with visual defects or strokes or TIAs, the vertebral with dizziness or visual stuff, the subclavian with arm claudication, the aorta, pulmonary, etc. It's pretty self-explanatory. The tragedy is all that you have in the beginning is a high SED rate, but no antibody that predicts what the disease process is. There's no lab test. The only thing that you're left with is a patient who has blood pressure differences, claudications, and blood vessels that cut off completely. And when you get patients at this stage, they're probably going to die. It's quite a sad disease process. So if you catch them early, we try to throw steroids at them, but it usually doesn't work because we don't catch them early. All that we're left to do is manage their blood pressure. Surgical intervention is usually the way to go. These days, the surgeons have got very inventive, and percutaneous transluminal angioplasty holds a lot of excitement for a disease process that really isn't that exciting. The other large vessel vasculitis is giant cell arteritis, formerly known as temporal arteritis, but as you fully understand, a lot of patients with giant cell arteritis don't necessarily have temporal symptoms. We've already mentioned to you that patients with giant cell arteritis have this very strong relationship with polymyalgia rheumatica, and it's argued that polymyalgia rheumatica is just a sort of bone joint manifestation of this vasculitis. And I don't want to repeat myself. On the other hand, this giant cell arteritis is a condition, again, of women, closer to the age of 70, but always over the age of 50. And very high prevalence in Scandinavian countries, very rare in blacks and Hispanics. There's several different subgroups of giant cell arteritis. Firstly, the cranial kind that we used to call temporal, where they present with headaches and jaw claudication and scalp hypersensitivity, and eye involvement that is particularly ominous and dangerous. CNS ischemia is described, and some of these patients have polymyalgia. Another variation of giant cell arteritis is the fever wasting syndrome, fever, weight loss, night sweats, and you all know of patients who present with fever of unknown origin, and in the differential diagnosis is always do a temporal artery biopsy. I don't know so much about that. I think it's quite a rare presentation. And then the third presentation that I want you to know about is the large vessel vasculitis. It sort of looks like Takayasu's, except it's a patient closer to 70. And this is a patient who presents to you again with claudication of upper, sometimes lower extremities, but with a very high SED rate. What will delineate this from atheroma is the very high SED rate. And obviously, on an arteriogram, a decent radiologist can separate this out. This subclassification or category of giant cell arteritis, these patients often lack cranial involvement. Their headaches are really not very pronounced. And sometimes they have PMR. So here in this particular cartoon, I just re-enumerate all the different manifestations of giant cell arteritis, temporal headaches, and it's not a mild headache. It's the worst headache I've ever had kind of headache. Sometimes with that vascular kind of quality that comes with it. The big fear is blindness. Other things that are described, scalp necrosis, tongue gangrene, jaw claudication, cranial neuropathies. As I say, in this particular cartoon, the ACR put together some criteria, and most of them are that your patient has to be over the age of 50, and that's pretty self-explanatory, and most of your patients, as I say, are closer to 70. The SED rate is very, very high. These patients have all kinds of systemic features, polymyalgia-like symptoms, fever, malaise, anorexia. And the local manifestations we've enumerated, I'm just hitting them again and again that you get it. An ophthalmologist is clearly a very important person for this patient to see. He or she may see signs or symptoms that help us further delineate the process, to include retinal or optic ischemia, which obviously tells us that our therapy needs to be quick and urgent. But it is not only the rheumatologist or the ophthalmologist that may be drawn into this kind of patient. It's the vascular surgeon, it's the cardiologist, and there's rarely cardiac involvement. Now, most patients don't walk in and say, "Excuse me, my temporal artery is slightly distended, will you biopsy it? I've got jaw claudication and I'm at risk for blindness." They have that kind of those three kinds of presentations that I've pointed out to you. But where a decent ophthalmologist is useful, you can see that, he or she would be able to see the obvious abnormalities or feel the obvious abnormalities and biopsy the patient for you immediately. So biopsy the abnormal site. Occipital presentations and facial presentations other than temporal presentations are described. Some patients don't have a temporal headache, they have an occipital headache. And that's well described. Again, on the boards, I don't think they'll play on that. They'll more play on the temporal artery kind of presentation. The Germans have sort of said that Doppler ultrasound guidance may help localize which part of the artery to biopsy. I'm not sure most of us believe or can really reproduce their technology. And so we'll go for the temporal artery biopsy. What's really key is that you need a decent pathologist, and not to suggest that every pathologist isn't decent. What I'm suggesting is that a pathologist who is used to looking at this kind of biopsy is the key thing. And I have one guy, my go-to guy, where I work every time, and we go and look at the slide together. I present the history to him, and we look at this. One of the first things he can do is he can say, "Okay, Paul, what I'm seeing is that the internal elastic lamina is interrupted." That's one of the first signs that he may pick up. Other signs, obviously, are round cell infiltrate all the way to giant cells, but you don't find that every time. And yes, of course you want a biopsy because you don't want to put a patient on 60 milligrams of prednisone without knowing that you've got your diagnosis right. The incidence of blindness has dramatically declined. You start them off with 60 milligrams and then you taper them down. You start them on a bisphosphonate. And the point to remember is that most patients with giant cell arteritis are off corticosteroids by a year or 18 months. If they're not, there's something wrong with the diagnosis. So it's not a benign diagnosis, but it's not a diagnosis that requires lifelong therapy. Very important point. Okay, so that's the large vessel vasculitic group, that is Takayasu and giant cell. Now, the medium vessel group is the one where the money is. It's where so many board questions are waged, and let's go into them. I don't think you'll be asked about Kawasaki, and very quickly it's infants and young kids who have a rash, conjunctival injection, mucous membrane changes with a strawberry tongue, cervical adenopathy, and in some patients, very rarely, you have to give IVIG for coronary aneurysms. As internists, we don't really deal with that. Before I get into the formal medium vessel vasculitic group, there are some who believe that relapsing polychondritis, this quite rare condition in which cartilage tissue of nose and ear becomes inflamed, is a medium vessel vasculitis, and I just throw it in here. I didn't want to admit this anywhere. And these are patients who have redness of their ears and of their nose. And I think in a board kind of question, it would be pretty easy to spot this kind of patient who has arthritis, hearing loss, vertigo, and sometimes they have laryngotracheobronchial symptoms associated, and you have to treat them with prednisone. And, it's pretty easy to diagnose these people. You can see that ear over there doesn't look normal. The nose over there doesn't look normal, and this kind of saddle nose deformity, Wegener's can cause as well. I can't tell you that that's definitely a patient with relapsing polychondritis, but I do want you to know the condition. But here are the conditions that we're going to pay attention to. Firstly, polyarteritis nodosa, originally known as periarteritis nodosa, described in a patient very beautifully who had fever, weight loss, abdominal pain, and a polyneuropathy. And if you remember that, you've basically got the diagnosis. I, in my life as a rheumatologist, haven't got to feel these nodular aneurysms along the muscular arteries, and it's felt that we don't get to feel them much these days because we treat patients with prednisone so early that you don't get that type of presentation. But polyarteritis is the prototype granddaddy medium vessel vasculitis. There's a rare association with hepatitis B and with hairy cell leukemia. I doubt they ask you that. Now, the American College of Rheumatology came out with a set of classification criteria, again, that I think are useless but are interesting in terms of helping you remember what the disease does. It may be very systemic in the way that it presents with fever or weight loss or livido, which is a non-specific rash, testicular pain, myalgias, weakness, but almost all patients are going to have a mononeuropathy or a polyneuropathy. Other things that they have are diastolic dysfunction, elevated BUN or creatinine. There's an association with hepatitis B, which I think is overplayed, but their arteriogram may be abnormal, and a medium vessel biopsy often is abnormal. Again, this is simply livido, which can be present in normal, healthy women more than men without vasculitic syndromes. It may be present in the antiphospholipid antibody syndrome, and it also may be present in a medium vessel vasculitis. Now, here's a patient with small vessel vasculitis. Some patients with a medium vessel vasculitis present with a small vessel vasculitis first, and it's only later on that you come to realize there's something else going on. And I'll come back and make that point in reverse later on. But here's the slide that's going to describe everything for you and to you on polyarteritis nodosa. The patient often presents with fever, weight loss, night sweats, arthralgias, that kind of stuff. But these patients tend to get skin, gastrointestinal, peripheral nerve, and kidney involvement. 80% of patients get a mononeuritis, a wrist drop or a foot drop, which is often dramatic and acute. And so when you hear wrist drop or foot drop, you start smiling because you know you headed towards polyarteritis nodosa. Lungs are spared. Lungs are spared. Did you get that? Please. The glomerulus is spared. The kidney may be affected by a medium vessel vasculitis that infarcts the kidney. But a glomerulus is a tiny blood vessel, right? So you don't get glomerular involvement. Sometimes orchitis, sometimes cardiac. The patient may have a GI tract involvement, transaminitis, or actual infarction of gut, which can be quite dangerous. The skin may be involved in a number of different ways, including palpable purpura, infarctions of skin, ulceration, livido, and subcutaneous nodules. But here's your classic presentation: an acute wrist drop or an acute foot drop. If I see that, I call my surgeon, I ask him or her to biopsy. In the case of a foot, I ask him to biopsy the sural nerve area. They'll get the piece of sural nerve, and then they'll also get a decent-sized medium vessel lives right next to. And you can see, looking at this artery, anybody can tell that this artery is affected by a panarteritis, intima, media, and adventitia. And you can see that it's already looking necrotic. This is a necrotizing panarteritis of a medium vessel. Differential diagnosis, number 1, polyarteritis nodosa. Next multiple choice question, please. Sometimes they may present, you may not realize what you're dealing with. The patient may have abdominal pain, and for non-specific reasons, somebody decides to do an arteriogram, and here you can see that the patient's blood vessels have little aneurysmal dilatations, and so that's how the diagnosis is made coincidentally. Renal and other blood vessels, hepatic, may be involved. There is a very special kind of polyarteritis nodosa called microscopic polyangiitis. My colleagues in Chapel Hill, Falk and Jeanette, about 10 years ago, got very interested in ANCA. And they started to talk about this disease. There was C. ANCA disease, which is Wegener associated, and then there's P. ANCA disease, which is not necessarily Wegener's, and there are other causes of a P. ANCA. We come into that in a second. But this condition called microscopic polyangiitis is polyarteritis nodosa with renal involvement with a P. ANCA association. And they said, in the past, we used to call this microscopic polyarteritis nodosa. But Falk and Jeanette, perhaps correctly, perhaps not, have forced this new diagnosis, microscopic polyangiitis. You need to know it. It has appeared on the boards quite frequently. And it is therefore, it's microscopic polyangiitis. Self-explanatory. There's renal involvement with a P-ANCA association. But there's other involvements. And the patient often presents with a rapidly progressive glomerulonephritis. And on biopsy, you see a focal, segmental, necrotizing glomerulonephritis. It mimics good pastures. It may have a pulmonary renal bleeding type presentation. So if you see hemoptysis and hematuria, you go for good pastures, and you also think about microscopic polyarteritis nodosa or polyangiitis. And you look at P-ANCA versus anti-glomerular membrane antibodies to help you bail out of your diagnosis. Now, polyarteritis nodosa is a violent disease process and less than 20% 5-year survival. You give corticosteroids if there's serious life-threatening involvement, and that brings your survival up to 50% remission, or the remission up to 50%. But where there's serious life-threatening involvement, again, you probably will add Cytoxan either intravenously or orally. The treatment of microscopic polyangiitis is very similar. We know that microscopic polyangiitis has frequent relapses, and so you have to treat these patients with prednisone and Cytoxan. There's a rare form of polyarteritis nodosa which is cutaneous only, and I tell you that there's 3 different kinds. I think I've got a picture of it right there. There's a patient with cutaneous nodule. You do a biopsy, and you get a picture that's typical, but I don't see that occurring in your boards. But what is on your boards quite frequently is polyarteritis nodosa with lung involvement, known as Churg-Strauss. I told you that PAN does not give you lung involvement. But Churg-Strauss is really PAN with lung involvement and eosinophilia. So this is a patient who often presents with asthma later on in life, and they have eosinophilia, and they have on a BAL eosinophils, but they look like PAN. They have a mononeuropathy, they have sinusitis, they have pulmonary infiltrates, and they have a vasculitic rash. So Churg-Strauss syndrome, such a rare condition. I might have seen 10 cases in my life, always on the boards. God knows why. Asthma, eosinophilia, pulmonary infiltrates, allergic rhinitis, peripheral neuropathy. CNS is rare in Churg-Strauss, but described. By the way, CNS is rare in PAN. Very rare, but described. Cardiac involvement occurs, pericarditis and myocardial. It's not such a benign prognosis, and it responds pretty well to prednisone, Cytoxan, perhaps interferon alpha. Another medium vessel vasculitis is the granulomatous medium vessel vasculitis called Wegener's. You want to think of Wegener's as having the following presentations. ELK, E for ear, nose, and throat, or sinusitis. L for lung or lower respiratory tract, which takes a whole number of presentations all the way from nodules to infiltrates to honeycombing of the lung. K for kidney, crescentic nephropathy. Not all patients have E and L and K. Some have E only, some have L only, some have L and K. And there's non-E and L and non-K disease. In other words, some patients with Wegener's don't necessarily fit that ELK kind of classification. But I think it's important to remember the ELK because it'll help you get to your diagnosis. But what will help you the most is the presence of what? C-ANCA. Love it. Okay, so here I've given you what Wegener's is. Sinusitis almost always. Abnormal chest x-ray. A urinary sediment with red cell casts or red cells. And on biopsy, there's a granulomatous inflammation. It is an aseptic inflammation with granuloma and vasculitis, but you don't always find granulomata on a biopsy. It's a very destructive process, and our ENT colleagues see a lot of this affecting the nose and the sinuses, and it may remain very localized in the ear, nose, and throat area only, with very significant consequences, not to be ignored. But it often has non-ENT presentations, and that's where we as internists will get dragged in, with the lung and the kidney and the skin, etc. C anchor, very useful in diagnosis. It's quite interesting, though, at presentation, most patients don't really present with renal nor lung involvement, and later on they develop it. And an interesting presentation is a lot of patients give you a history of having otitis media several months prior to onset, and we can't quite explain that. Other things that patients get are epistaxis or mucosal ulceration, sometimes proptosis, and may present an ophthalmologist with an orbital mass, or necrotizing scleritis. They have very pronounced otolaryngeal symptoms in some patients, pulmonary infiltrates, and then on biopsy of the kidney, you see a glomerulonephritis, which is pauci-immune. I repeat that, not a lot of circulating immune complex deposition. Patients may have this kind of presentation, which is very relapsing polychondritis-like when you think about it, saddle nose deformity. This is a lethal condition, and in the older literature prior to 1960s, the patients lived 5 months. But with the addition of prednisone and Cytoxan, we can at long last talk about a 50% cure rate, meaning that 50% of patients no longer require prednisone and Cytoxan, and most patients will be given prednisone and Cytoxan for about a year until they've been in approximately a year's worth of remission. If a patient is really not flared for a year and had prednisone and Cytoxan and they're doing great, you can consider getting rid of those drugs and praying that they don't recur. Unfortunately, about 44% of patients recur within a 5-year period. What is useful for the diagnosis is the C anchor, which is a protein against, an antibody against, proteinase 3. May be asked on a board kind of question, you never know. C anchor is more specific, more common in Wegener's, but may be seen in other conditions. Some people have argued that a titer is particularly useful in diagnosing Wegener activity. I think a board question will not ask you that because it's somewhat contentious. Treatment is prednisone and Cytoxan with a goal of getting your white count between 3 and 4,000. Obviously, if your patient is on 60 milligrams of prednisone, their white count is going to be closer to 20,000. So you don't want to push the Cytoxan hard early. But what you will do is slowly taper their prednisone down, and once you've got them between 5 and 10 milligrams of prednisone, you're going to start pushing the Cytoxan so that you can get your white count closer to 3,000 or 4,000. That's our goal. We're very scared of hematuria, and those patients who get bladder cancer later on in life have had hematuria for a long period of time. So we monitor for that very closely. There's a concern about pneumocystis, and many patients are given a prophylactic treatment for pneumocystis who are on a regimen of Cytoxan at the doses that I spoke to you about. There are some alternative therapies to oral Cytoxan, including IV Cytoxan, Bactrim given for 6 months after you discontinue Cytoxan. There's some evidence to show that relapses are reduced, and methotrexate is used particularly for localized Wegener's. There's an interesting condition called lymphomatoid granulomatosis, which is sort of an overlap between a lymphoma and a small vessel to medium vessel vasculitis. I just mention it there. I think you've got the slides. I really doubt a board question, so I'm spending very little time with that. I do want you to remember, and I've already alluded to this, that vasculitis is associated with other connective tissue diseases from rheumatoid to lupus, but not scleroderma. So sometimes you'll see a question and you're really not sure if a patient has vasculitis or a connective tissue disease process. I wouldn't worry too much. I think that kind of question would be more focused on how do you treat the patient, and I think you're probably safe in starting them on prednisone, and if you get a sense by looking at your question and your patient that there's a life at risk, you probably want to put your patient on Cytoxan. There might be questions in terms of which autoantibody you would use to bail you out. If it's Wegener's, we've mentioned already that it's likely to be a C anchor, and we've mentioned the P anchor with microscopic polyangiitis. Behçet's, we've spoken about this, and it's so common in the boards. I just reminded you what Behçet's is, and I've stuck it in here because there are some who feel that a Behçet's is a form of vasculitis. I really don't have a strong viewpoint about that. There is a condition of primary CNS vasculitis, and I've already hit you hard with the fact that lupus does not give you vasculitis. When you do an arteriogram of a patient who has CNS disease with lupus, you don't find arteriographic abnormalities. Most patients with lupus who stroke have antiphospholipid antibodies. They don't stroke from their lupus. On the other hand, there's a condition called primary angiitis of the central nervous system, which I think you are expected to know. And there's several flavors. The first flavor is a non-good kind called the granulomatous CNS vasculitis, in which you find young individuals who have vasculitis of different parts of their brain, often with an abnormal CSF, and the biopsy is often of a high yield, more common in males who present with headaches and seizures and mental status changes, whose prognosis is not good. There's another flavor called benign CNS angiopathy, which tends to occur in younger women, sometimes who are pregnant, or there's a relationship to pregnancy. The pointer that tells you that you're dealing with a more benign variant is that their CSF tends to be normal, whereas the granulomatous kind, the CSF tends to be abnormal. This group has an arteriogram that's also abnormal, and they don't necessarily have to get hammered with prednisone and Cytoxan to the same extent that the granulomatous kind does. There's a subgroup that fits neither, what we call the atypical. But I think it is important to exclude drugs and toxins and never be caught out with pseudo-ergotism. Ergot-like drugs are those that are taken for migraine. But causes of pseudo-ergotism, in other words, CNS vasoocclusion, are, the most common drug is cocaine. Remember that. Young patient who strokes, think cocaine. HIV can do it. Zoster can do that as well. Oh, I think I've already mentioned that. An arteriogram is sometimes necessary. An MRI sometimes can bail you out. I cannot think of a board question that they could phrase in such a way that you would be asked to pick one from the other than to know that both can be abnormal and are very difficult for really brilliant neuroradiologists to delineate vasculitis from other causes at times. And all of us get involved in debates as to what the patient really has and whether or not to biopsy their brain or not, which is a very aggressive clinical move. A condition that you are expected to know about that isn't a true vasculitis is thromboangiitis obliterans, also known as Berger's disease. And this is an idiot who smokes. And I have patients who are missing digits from Berger's disease and still have the talent to stick that cigarette in their mouth. And this is a patient who has both arterial and venous disease, and they do horrifically. There is no therapy other than to beg them, as I have done on many occasions, to stop this stupid habit. Okay. Small vessel vasculitis. There's many different kinds. That which we call cutaneous leukocytoclastic, that's which we call Henoch-Schönlein purpura, cryoglobulonemic, and one or two others that I mentioned, and let's focus on these because they love them on the boards. Here's a patient with a vasculitic rash. I don't know what it is, so I go and biopsy it. And the pathologist who comes in at about 10 o'clock, I'm kidding, and looks at the specimen and calls me about 3 o'clock on her or his way home to say, I see leukocytoclasis. What they're saying is that they see in a post-capillary area, they see breakdown of polymorph, debris in a post-capillary venule. That's all they're saying. That's when we say leukocytoclasis, many different causes. I beg you to remember this little cartoon right here. Okay? What this is saying to you is that if you get a patient like that rash that we've just biopsied, these are the things you want to consider. It might be drug-related. It might be idiopathic, which is the overwhelming majority of patients. On the other hand, it might be associated with HSP. We come into that. with an infection. You need to ask questions about an infection. It might be associated with cryoglobulins. We're coming to that. It might be part of a systemic vasculitis, like lupus or like PAN. So there are many, many causes of a small vessel vasculitis. But the patient quite clearly doesn't have lupus or quite clearly doesn't have PAN, then you're stuck with that idiopathic group. And the American College, once again, has to go away on a conference, 12 idiots who call themselves experts, go to Tunisia, nowhere close, somewhere exotic, and they have to decide we need criteria. And it takes them 2 weeks to work out these mindless criteria. I'm kidding. And here the criteria are: age greater than 16. I mean, some of them are silly, but the bottom line is it's a patient with a rash who on biopsy has vasculitis. Okay, now, here we have a patient with lower extremity vasculitis. Differential diagnosis that goes through your head straight away is number 1, HSP, number 2, cryoglobulinemia, and number 3, idiopathic leukocytoclasis. So, I don't know what it is, and I decide if it's a kid, then HSP is more likely, particularly if there's a buttocks rash as well, particularly if it occurs during certain months of the year where it seems like spring is more common. HSP, usually a kid but can be an adult, who has purpura, arthritis, abdominal pain, and glomerulonephritis. They love this on the boards. On biopsy, there's IgA deposition. Most are kids, younger than the age of 10. Kids tend to be more benign in the way they conduct themselves in general, but specifically with HSP. Adults do get glomerulonephritis, which may require prednisone and or Cytoxan. I see a lower extremity rash. I say to myself, whoa, could this be cryoglobulinemia associated? Cryoglobulins are proteins that precipitate in the cold. I take the patient's blood. I get my phlebotomist to take it to the lab at 37 degrees, allow it to clot for 30 to 60 minutes, and then I spin it down, take the serum, and stick it in a fridge. I come back 2 or 3 days later and see some protein in the serum. That's a cryoglobulin, more than likely. What do they mean? I have no idea. So I get the laboratory tech to do an electrophoresis. And Brouet did this, and he came out with 3 different kinds. A monoclonal electrophoresis was type 1, associated with myelomas. A polyclonal and monoclonal picture was type 2. And for many, many years, we walked around talking about mixed essential cryoglobulinemia, and we've now come to discover that 90% of mixed essential is what? Hepatitis C. And then a type 3 where you have 2 polyclonals, which is really a circulating immune complex. It doesn't mean very much. So you would do cryoglobulins in somebody who presents with a lower extremity rash. You would also check for cryoglobulins in someone who is weak or has arthralgias or who has very bad Raynaud's or who has a neuropathy, motor and sensory, or who has a membranoproliferative glomerulonephritis. But you would probably do it in the year 2004, the most, in a patient who has all of the above plus a transaminitis, and you'd be looking for hepatitis C. Sometimes patients get infarctions in funny areas like in their ears or bad Raynaud's. Sorry, I jumped the slide. You are expected to know how to treat hepatitis C, aren't you? Yeah. And of course, there's 3 different kinds. The first one that doesn't respond particularly well to PEG and are the viral therapies, and 2 and 3 which tend to. I guess my teaching point is if you've got a patient with cryoglobulinic hepatitis C vasculitis and they have a wrist drop or a foot drop, you have to put them on prednisone and Cytoxan and come back 2 or 3 months later and treat their hepatitis C. On the other hand, if it's a mild rash and you're not particularly worried that they're at risk, you would treat their hepatitis C first. So they could phrase a question in either direction, and you have to use your common sense there. You have to say to yourself, what do I really need to do here? What do I need to do first? And there's a long debate as to which is worse, and often us clinicians are debating which to do first. Because we're concerned that by giving prednisone and Cytoxan, that you're going to increase your viral load and therefore make the disease worse. There's another interesting kind of vasculitis called urticarial vasculitis, where these patients look like a vasculitic syndrome. They're very itchy. You see it in lupus and Sjogren's, but sometimes it's idiopathic. On biopsy, you find C1q deposited. So the crystals, gout, pseudo-gout, and others. Look, gout is a really easy diagnosis that is made clinically by aspirating a joint, a relevant joint. It is not based on a high uric acid level. You can make the diagnosis by aspirating a joint, number one, or you can find a tophus. I don't know that a tophus is a tophus. It could be a nodule. So I stick a needle into the tophus, I aspirate it, send it off to the lab or look at it myself, and I look for crystals that are YPG, yellow parallel gout. We'll come back to that point. Another way that we can make a diagnosis of gout, I suppose if a patient's had multiple episodes and all of this other junk that I've enumerated here, but I don't really, as a clinician, trust these other things. I want to aspirate a joint, or I want to find a tophus, or I may settle for an X-ray appearance that is classic. Now, firstly, not everybody with gout has hyperuricemia, right? You will see normouricemic gout, and that might be a very fair board question, where a patient is briefly acidotic or dehydrated or had some traumatic event and is precipitating an event of gout, yet their uric acid levels are normal. On the other hand, many patients have hyperuricemia and never develop gout. You never treat hyperuricemia per se, unless uric acid levels are phenomenally high, unless there's a family history of gout, in which instance you suspect that they're overproducers, unless they've had renal calculi, or unless another reason to treat somebody with hyperuricemia in the cancer situation of myeloma or something like that, you might briefly want to do it during induction chemotherapy or something like that. And another indication you could argue to treat hyperuricemia is in a very young individual, 20, 22, with phenomenally high uric acid levels. I would treat that kind of patient. They're clearly at risk to develop gout later on in life and or renal calculi. Now, so let's think about hyperuricemia. There are many, many causes. Of course, drugs and all the secondary causes are the ones that come to mind first. And alcohol, which changes the ratio of NAD to NADH, and therefore changes the reabsorption of uric acid at a multitude of different levels. But we always have to think like internists as we approach the board. So the hemolytic anemias do this, drug therapies, diuretics do it, low doses of aspirin, pyrazinamide does, cytotoxic drugs, ethambutol, cyclosporin. The drugs that are used for immunosuppression with transplantation are clearly some of the worst cases of gout that I get to see. And I wouldn't think it's unreasonable to ask a board question along that line. The primary kinds, the overproducer kinds, those are the ones where there's a family history without necessarily the Leishmanian, which is the self-mutilation type. But there are many other enzyme deficiencies which you're not expected, I don't think, for your board questions. But you will spot these patients in the history, in that this is a patient where the mother and the brother and the cousin are all married. No, I'm kidding. All have gout. And if a young woman has gout, then you've got to suspect she's either an abuser of diuretics, as in the anorexia kind of situation, or she has this family history with an enzyme deficiency. Women get gout post-menopausal, particularly when you pour on the diuretics. Hypertension, lead, nephropathy, myeloproliferative disorders, and I don't think it's unreasonable that they sneak in a sort of a myeloma kind of patient who happens to have gout. Obesity is associated with hyperuricemia, renal insufficiency, etc., toxemia of pregnancy. Now, an acute gouty episode is usually a lower extremity presentation. 50% of patients with gout develop their first attack in their big toe, podagra. 50% therefore don't. But 90% of patients with gout at some stage, have podagra. In other words, if you're getting a patient or a question where the patient has never had a first tarso-metatarsophalangeal joint involved, you're suspicious that they don't have gout. Most cases of gout present as a monoarthropathy, lower extremity. Be careful. That doesn't always apply in the boards or in life. And so if you get a patient who has polyarticular presentation, they could have polyarticular gout. If you have a patient who has an upper extremity presentation, we spoke about the favorite kind of board question with someone with a Heberdin's node who's on a thiazide diuretic, you're not going to be caught out in that particular presentation. You know, if a patient has one attack of gout, you're going to treat them. So let's talk about an acute presentation of gout. You're going to treat them with a non-steroidal. Well, if I had acute gout, don't come at me with a non-steroidal. If I had acute gout, please stick a needle in my joint, if I'm willing to let you do it, in order to confirm the diagnosis, or give me steroids, please. Just a dose pack of prednisone. That's the treatment of choice. You guys all have this bizarre notion that colchicine is the drug of choice. It is not. And I don't think board questions will be written as such. Okay, because colchicine is pretty toxic. It takes a long time to work. And I don't want to have a painful joint be lying around cringing with gout, and then you make me throw up and have diarrhea and to tell me that I'm now feeling better. So I have this sense that who writes the board question will be kind of reasonable. But I guess you're still expected to know that colchicine is one of the treatments of gout. These days we don't use that drug intravenously at all. So, how do we make the diagnosis? It's with a polarizing scope. YPG, the red compensator, will always be told to you what direction it is. And if it's yellow and parallel to that red compensator, it's gout. And if it's the other way around, obviously it's pseudo-gout, so YPG. And you can see that clearly. I can just guess what direction that red compensator is there. So yellow parallel gout. We don't need to know what that is. I mean, that's tophi. You know, I can't imagine that they'd show you a picture like that, but if you see that, you'll get that pretty easily. And obviously, it's too late for drugs like probenecid. You're going to have to prophylax that kind of patient. Here's your classic patient who presents with podagra, which is a very irritating, erythematous, painful, acute, often precipitated condition, precipitated by alcohol, trauma, surgery, that kind of stuff, infection. But sometimes you don't only get it in the big toe there. You can see that's an ankle joint that looks pretty angry. Sometimes you diagnose the condition. You don't have to actually aspirate the joint. And don't forget to look for tophi in a patient with an acute presentation. They may just have had tophi for a long time, but they don't know. And we always talk about the ears as being a common site, but more common is around the eyes and much more common around the elbows or fingers. And the tophi are usually easy to spot. Here's an X-ray which reveals evidence of what looks like soft tissue calcification compatible with a tophus. But if you're a really good radiologist, you will see erosions, and they will describe the erosion as follows: that the erosion has an overhanging margin. So if you hear a question in which they talk about erosions with an overhanging margin, that is typical of gout. And I don't think we have too much time to go into that. Here's the patient with osteoarthritis who gets gout, and you can see that she's got tophi on that left fourth DIP. So treatment of gout, non-steroidals, colchicine. The problem again is the GI side effects. ACTH, we don't use that drug much these days. We kind of go to steroids given in a dose pack form, something like that. When do I prophylax and who do I prophylax? Anybody who has had recurrent attacks of gout. The definition of recurrent varies. I mean, for me, if I had an attack of gout 3 months ago and I have another one now, 3 months later, I'm saying, enough, I don't want this, prophylax me. But some patients are lucky and they have an attack 6 years ago, and now again you can say, well, I really don't need to prophylax that person. You can use colchicine for prophylaxis, but it doesn't lower uric acid levels, but it does definitely prevent recurrent attacks of gout. What they love to ask on board questions is that colchicine is associated with a myopathy, a sort of a neuromyopathy where patients are actually weak, and they may even offer you a biopsy of muscle which shows vacuolation. colchicine-induced vacuolated myelopathy. Oh my gosh, if they ask you that on the boards, that's eccentric, and all of you are going to get it right. Okay, now, we have a choice in terms of prophylaxing a patient. Firstly, they have had to have multiple attacks of gout, or they have hyperuricemia, which is exceptional, or they're very young, or they have a family history, or they have, what else did we speak about? Chemotherapy. Now, essentially, there's two kinds of patients with hyperuricemia. Really, three. If a patient's on a drug like a thiazide diuretic or low doses of aspirin or drinking alcohol, you've got to stop that. But if they're not on any of those drugs, then you're dealing with one of two clinical situations. They are either under excretors, 90% of patients, whose kidneys are simply not kicking out uric acid adequately or efficiently. We don't know why, because their kidney function is normal. 10% of patients fall into the overproducer category. And that's the patient you can spot. You don't need to do a 24-hour urine uric acid. That's the patient with the family history. So most of the time, I don't bother to do the 24-hour urine. I look at the family history, and I guess that they're an under-excretor. Under-excretors get probenecid, unless they've had renal calculi or renal dysfunction. Those are the two absolute contraindications to the treatment for prophylaxis with probenecid. All other patients get allopurinol. Probenecid is a safer drug than allopurinol in that you don't get the side effects from allopurinol that we fear. The worst side effect from allopurinol that you will see is the Stevens-Johnson TEN, toxic epidermal necrolysis kind of patient. But more common side effects from allopurinol include rashes, thrombocytopenia, leukopenia, aplastic anemia, transaminitis, granulomatous hepatitis, all the way to more sinister forms of hepatic dysfunction. There is a syndrome which you may be asked, and that is the allopurinol hypersensitivity syndrome, which describes usually an older woman in whom the gout hasn't even been proven, who is sometimes diabetic, has mild hyperuricemia, and has minimal renal dysfunction. And if you give that patient incorrectly allopurinol for presumed non-crystal proven gout, they get transaminitis, rashes, TEN, thrombocytopenia, and you don't want that. The allopurinol hypersensitivity syndrome. I think just know it. I don't think you'll be asked it, but again, you want to be one step ahead. I think the difficult gout patient is the patient who's very young and very difficult to treat, particularly those family kinds of abnormalities. The transplantation patient who's on big doses of diuretic, which for self-explanatory reasons, and you can't get rid of the diuretic. I mean, if it's a cardiac transplant or if it's a renal transplant, you know why they're retaining fluid. And they've got to get cyclosporin. So those are some of the most difficult patients that you'll ever get to treat. Be careful of women. If you're told that a woman has gout, make sure that your diagnosis is correct, particularly if she's young. But the postmenopausal woman, what estrogen does is help uric acid be resecreted. You lose your estrogen, you can't resecrete uric acid, you accumulate uric acid, and you add a thiazide diuretic, you compound the problem. Again, I have pointed out there is such a condition as normouricemic gout. Okay, pseudo-gout. These are crystals that are positively birefringent. We define gout crystals as negatively birefringent, just that's the way we've set up the terminology. Gout crystals are very positively negatively birefringent, meaning that the colors of yellow and blue are very stark and very clear. Crystals of pseudo-gout are positively birefringent, meaning that they're not yellow, they're blue parallel. And the colors yellow and blue are very light. They're difficult to see. Therefore, this kind of crystal is often missed by a lab tech or even by a so-called competent rheumatologist. Pseudo-gout is a condition that mimics gout, and it's a crystal of pyrophosphate, calcium pyrophosphate deposition. Now, you will be asked this kind of question in a number of different ways. You will be asked, firstly, what are the associations of pseudogout, of calcium pyrophosphate? It's with high age, high calcium, and high iron. So elderly patients, hyperparathyroidism, and our old friend, hemochromatosis. And there's several other weaker associations, including gout and ochronosis and Wilson's disease and a whole bunch of other junk, which I don't think you'll be asked about. But I think you'll be asked about it more in the hemochromatosis kind of manner. And we'll come to that in a second. There's several different ways that a patient can present with pseudogout. They can present where you're doing an x-ray for joint pain and you see calcification, soft tissue calcification of the hand, sometimes of a ligament or fibrocartilage called the triangular fibrocartilage, which you might see over there. This is not showing up very well. Or just soft tissue calcification. And that's what we call a coincidental kind. Now, please pay attention to this x-ray because it's not unreasonable to be asked this. Can you all see this area of chondrocalcinosis? Chondrocalcinosis simply is a medical word for calcification of cartilage. If I'm 80 years old, it's not surprising that my cartilage is calcified. On the other hand, if I'm 50, it is surprising. And therefore, I would suspect that chondrocalcinosis in a 50-year-old may be associated with crystals of calcium pyrophosphate. So another way that I can diagnose pseudogout or calcium pyrophosphate deposition disease is by the finding of chondrocalcinosis. Are you with me? Okay, now, these crystals are calcium pyrophosphate crystals, and they're blue parallel. I think I've hit you with that point 1,000 times. There are many different ways that patients with pseudogout present. They love the following question on the boards, where a patient is in the hospital and they had an operation for bunions 3 days ago, and Mrs. Smith suddenly presents with an acutely swollen knee. Or she had an infection, she was admitted for pneumonia. And that one joint, they want you to aspirate to make sure it's not an infection, and then they'll tell you that there's crystals of calcium pyrophosphate, or expect you to know that. Okay? So, one acute joint, usually lower extremity, that's one way that pseudogout can present. Sometimes it can present with multi-joints. It looks like rheumatoid. That's quite rare. Sometimes it presents like osteoarthritis, and that's pretty rare too. Sometimes these patients you happen to do an x-ray and you find chondrocalcinosis. How do you treat these patients? Look, if it's one joint, you prove it's not an infection, you come back and inject corticosteroids a day or two later, once you know it's not an infection. Or if it's clearly not an infection, you can inject them immediately. Or you can try non-steroidals. There's no way to prophylax them, though we do try colchicine, and it seems to work in some patients, preventing recurrent attacks of pseudogout. All right, there's another kind of crystal that you're expected to know, basic calcium pyrophosphate. This presents in a number of different ways. This is a patient who might present with shoulder pain, and you do an x-ray and you see soft tissue calcification. Usually occurs in the elderly. Sometimes you do an x-ray and it looks like osteoarthritis, but you've got these soft tissue calcifications. Again, you can suspect the crystal of basic calcium phosphate. I don't know that they're going to expect you to know this, but one of the dyes that will help you when you do an aspiration of a joint is the alizarin red S staining and perhaps x-ray diffraction. That's much more for a rheumatologist to know. But what you might be expected to know is this condition called the Milwaukee shoulder syndrome, which is an elderly woman with severe and pronounced shoulder pain and shoulder joint destruction. That on aspiration of this joint, you sometimes find a bloody fluid, bloody aspiration with basic calcium pyrophosphate crystals. Now, moving away from crystals, let's get to infections. And obviously we can't cover every kind of infection. I'm giving myself another 40 minutes to go through some of this stuff. But some of the infections that you're expected to know are in the following types of situations. Firstly, you are expected to know that an infected joint is more likely to occur in a joint which is abnormal, whether gouty or rheumatoid or a replaced joint, and particularly prosthetic joints are particularly susceptible to infections of a myriad of kinds. Then the immunocompromised patients, all the way from the simple diabetic whose control is not so good, all the way to a patient with HIV or a patient who's immunosuppressed or receiving chemotherapy for one reason or another. The thing to remember about bacteria is they love to adhere to biomaterials used in joint replacements, and it remains a major problem. The thing to remember, though, if you suspect a patient has a septic joint, if you're playing the odds, it is still likely to be gram-positive, and the kind of coverage that you would be expected to know would be predominantly gram-positive. There are some situations where you expected to think of a gram-negative infection, particularly in diabetics. Patients with HIV, Pseudomonas is described. Most infections are monoarticular. So, if there's some patient in your board kind of question that you're expected to diagnose that they're septic, 90% of the time it's one joint only. It is rare to have multiple septic joints. Okay. The white cell varies, and most of the time it's closer to 100,000, but it doesn't have to be. Remember the pseudoseptic treatment, that pseudoseptic presentation that you get in psoriasis and you get in reactive arthritis. So I just enumerate for you some of the organisms, the gram-positive ones, the gram-negative ones, and I want to go through some specific kinds of infection that they love. One of the ones they love is the gonococcal arthritis, obviously in somebody who is sexually active, but in the era of Viagra, I think age groups have lost all definition, as I discovered with one of my patients recently. These are patients who present with polyarthritis, tenosynovitis, and dermatitis. They're usually on acute febrile presentation. They have this diagnostic skin lesion in 40 to 70%. They're a particularly purulent arthritis, and they may have other things like meningitis and myopericarditis. The treatment, as you know, is ceftriaxone. There's a problem with resistance, and don't forget, GC doesn't travel on its own. It keeps some particularly bad friends. Chlamydia, etc. I mean, there's the pustule, and that's a particular giveaway. There's a better close-up of the pustule. So that's one none of you will get wrong, okay? I'll be very sad if you do. All right. Musculoskeletal syndromes associated with HIV. These are patients who might have arthralgias, but I think you always want to remind yourself that they can have particularly weird, opportunistic infections of skin, of joint, and of muscle. And they get pyogenic muscle infections, what we used to call Reiter's-like syndrome, and I needed to change that slide. I guess that just escaped my attention. They have a psoriatic-like presentation. Myositis, they sometimes present with Sjogren. So those are some of the musculoskeletal manifestations of HIV, and you're going to be asked HIV in so many different ways. And I don't know if musculoskeletal one will be one, but anyway, we've covered it. They sometimes get a very non-specific spondyloarthropathy-like presentation. They get avascular necrosis of bone, and there are many other causes of AVN. I'm sure you're going to cover Lyme disease under your infectious disease thing, but let's just remind you, Lyme disease, the certain parts of the country that you see it, some that you don't. ECM, flu-like presentation in the early stages. In the secondary stage, you can have joint pain, meningoencephalitis, Bell's palsy. Thinking of Bell's palsy, what else gives you, other than Lyme disease, gives you a bilateral lower motor neuron seventh palsy? Sarcoid, right? Just reminding you of other things. Stage 3 of Lyme, which is more the carditis and the CNS kind of presentation. And treatment of Lyme, you obviously need to do by yourself, and it'll be covered elsewhere. Septic olecranon bursitis. They love bursitis on the boards, and if you get a patient that's described who's got this hot, red, tender area, what they want you to do is aspirate it and probably get them to an orthopedic surgeon who's going to open that up and do a bursectomy, and you would treat them with antibiotics for quite a lengthy period of time. So the approach to somebody where you suspect bursitis that is septic is very aggressive. Aspirate, orthoconsult, antibiotics for a long period of time. And it just depends how they write that question. There's not just olecranon bursitis. There's 5 bursa around the knee, pre-patella, anserine, no name, no fame. That's genuinely a kind of bursa. And so this is a patient who looks like a septic pre-patella bursitis, and again, pretty aggressive approach. Parvovirus B19. Slap cheek in kids, but you don't usually get the slap cheek appearance in adults. What you tend to get, of course, it's erythema infectiosum. It tends to occur late winter and spring, and you get diffuse arthralgias. Chronic arthritis per se is rare, and in the HIV situation, and even in the non-HIV situation, you get a transient aplastic crisis. All right, so the B19 patient's not going to slip through your attention. Hepatitis. Hepatitis C, we've already spent a lot of time talking about mixed essential cryoglobulinemia. Patients often have arthritis and palpable purpura, membranous proliferative GN, and you treat the underlying disorder, namely the hepatitis C, first, unless you very much think the patient is at risk for something serious, and then you would treat them with prednisone and cytoxan for a while and then come in and treat the hepatitis C next. But hepatitis B is something to be borne in mind. These are patients who sometimes present with circulating immune complex kinds of symptoms, with arthralgias, sometimes arthritis. And their arthritis is more a transudative, more of an arthus reaction rather than it is a direct involvement of the joint per se. I've already pointed out that there is a weak association with PAN. Rheumatic fever, often asked on the boards. How do you spot the rheumatic fever? The interesting thing is that sometimes there's pain disproportionate to physical findings, number one. Number two, the joints occur in succession, what is known as a flitting arthralgia or arthritis. Number three, the joint disease occurs early in the disease. It's almost always transient, and the legs first, arms later. Those are just some clues to rheumatic fever. Treat them with aspirin and non-steroidals. Okay, we're talking about conditions in which you get musculoskeletal manifestations in miscellaneous conditions such as renal failure. Now, renal failure does a bunch of different things. There's a condition of renal osteodystrophy with secondary hyperparathyroidism, sometimes clubbing, bony pain, arthralgias, and an enthesopathy. Then there's another condition with aluminum-induced bone disease with quite significant pain. Sometimes in renal disease, you get periarticular calcification. Patient just comes in to see you with shoulder pain, and you x-ray them and you see soft tissue calcification. It's just part of their dialysis or part of their disease, not much you can do about it. However, you guys are never going to be caught out by the patient who is dialyzed, who develops carpal tunnel entrapment, arthritis, synovitis, shoulder arthropathy, hip and wrist arthropathy. They look like rheumatoid. You're going to biopsy them and you're going to find what? Beta 2 microglobulin deposition, a form of hemodialysis-associated arthropathy. Very reasonable to ask you on the boards. Asterisk that one. There's a patient with hemodialysis who has just very destroyed-looking joints, non-specific picture. Okay, paraneoplastic syndromes. Patients who have cancers sometimes present with proximal weakness. As we've mentioned, they look like dermatomyositis or polymyositis, but they can have an Eaton-Lambert or a myasthenic syndrome. Eaton-Lambert is obviously reverse myasthenia. They have arthropathies sometimes. There's a condition of hypertrophic osteoarthropathy. We'll describe that for you in a second. But, some of the neoplastic or paraneoplastic manifestations might just be secondary gout. There's a very rare condition of carcinomatous polyarthritis. I've been a rheumatologist 19, 20 years. I've never seen that. I guess if they ask you that on the boards, they're nuts. There is, though, a condition that I think is fair game to ask you as internists, and that's hypertrophic osteoarthropathy, what we used to call hypertrophic pulmonary osteoarthropathy, but we've come to understand that it's not always pulmonary. And in the old days, it was a patient who has intrathoracic sepsis or neoplasm, somebody with bronchiectasis or a lung tumor, and they developed clubbing and or wrist and ankle pain. And the big clue is that on X-ray, do I show you an X-ray? Well, I'll give you several other causes of hypertrophic osteoarthropathy. Let me just go back. So there's a primary form, there's a secondary form, there's pulmonary disease, which is either an infection or a neoplasm. There's a secondary form, as in cyanotic congenital heart disease, but it doesn't have to be pulmonary, as we point out. It's gastrointestinal, cirrhosis, inflammatory bowel disease, etc. What's typical of these patients is that they clubbed, they have arthralgias of the wrist and ankle, and on X-ray, I didn't give you the X-ray. On X-ray, you see a periosteal reaction, meaning that you see periostitis. So if someone describes periostitis on an X-ray, you're all over that one. Okay, endocrine manifestations in joints. Hyperparathyroidism does a number of different things. It gives you osteitis, fibrosis cystica. It can give you erosions which can look rheumatoid-like, but a decent radiologist, again, one who does this for a living every day and looks at bones, can delineate them out. You do see chondrocalcinosis and pseudo-gout in hyperparathyroidism, sometimes ectopic calcification, and a myopathy which is argued to be a neuromyopathy. Other endocrine things, acromegaly. These patients get synovial thickening, bursa hyperplasia, capsular thickening, increased muscle mass. But Andre the Giant throwing people out of the ring is a joke. These are patients who are, with acromegaly are proximally weak. They're not that strong. Carpal tunnel and tarsal tunnel entrapment is described in acromegaly and other peripheral neuropathies. They get premature osteoarthritis and kyphosis. Hypothyroidism, we've already mentioned this in an indirect manner. These are patients that are proximally weak with minimally elevated muscle enzymes, but they get other problems, Charcot-like joints, hyperuricemia, and an unexplained tenosynovitis of tendons, usually in the flexor tendon. And as I point out, they get carpal tunnel entrapment and a myopathy with mild CK elevation, but they're not all that weak. On the other hand, patients who are thyrotoxic can get a thyroid acropathy, which includes pretibial myxedema, clubbing, exophthalmos, and the LATs, long-acting thyroid stimulator. As we pointed out before, they have a myopathy with profound weakness but normal muscle enzymes. Here's a question that I think is very fair game. Diabetic limited joint mobility syndrome, also known as diabetic algodystrophy. I don't think anybody would go back and ask you a question like that. But these patients have a positive prayer sign, meaning that you ask them to put their hands together like that, and they can only do this. When you grab their skin, it's thickened. They have pseudoscleroderma. It's not an uncommon condition. They also have adhesive capsulitis, frozen shoulder, and we're going to talk about other causes of a frozen shoulder. Charcot joints, pseudoscleroderma, neuropathies, Dupuytren's is all part of this diabetic limited joint mobility syndrome and frozen shoulder. Dialysis arthropathy, we've spoken about that sort of indirectly through amyloid, through crystals. Sometimes you just get a frank destructive arthropathy unrelated to crystals. Another sort of miscellaneous condition often asked on the boards is amyloid. So let's just remind you about amyloid. Usually, sometimes associated with myeloma, but there's many other kinds of secondary amyloid, sometimes running in families. But we can delineate primary from secondary amyloid in a number of interesting ways. Patients with primary amyloid tend to get more the purpura, the bleeding tendency, the big tongue. Other causes of a big tongue are hypothyroidism, Down syndrome. Arthropathy, restrictive cardiomyopathy, neuropathy, nephrosis. That's the primary generalized. But the secondary that you get in rheumatoid or in juvenile idiopathic arthritis or in bronchiectasis tends to give you more the nephrosis and the cardiomyopathy. And I've enumerated, and the hepatosplenomegaly. And I've just given you all the different things that you tend to see in the secondary. Sarcoid, often asked on boards. Always asked on boards, I would argue. A chronic granulomatous condition that can affect any organ, can sometimes affect joints, but not that commonly. It tends to give you more cystic bony lesions. As we've mentioned, it can be any kind of organ involvement, hilar-adenopathy with a benign prognosis, pulmonary, uveitis, carditis. It's a cause of restrictive cardiomyopathy. Other causes of restrictive cardiomyopathy are scleroderma and amyloid. Neurologic and skin are other sarcoid involvements. Skin lesions, erythema nodosum, both ocular involvement, iritis or posterior uveitis, both are described. Hilar-adenopathy, pulmonary infiltrates, energy by testing. Angiotensin-converting enzyme, as you know, it's not particularly a good SED rate. You can have patients with bad pulmonary disease but with a normal ACE level and vice versa. Don't forget the hypercalcemia, hypercalciuria. Don't forget the thing I told you about, the seventh nerve palsy, which is bilateral, also seen in Lyme's disease. Acute sarcoid is a very interesting presentation, particularly where there's very bad ankle involvement. If you get a board question where they're talking about a young woman, let's say, who's got very bad ankle arthritis, please think of sarcoid. Sarcoid in the acute presentation loves the ankles, and all of you know Lofgren's presentation, right? With involvement of E. nodosum and hilar-adenopathy. So ankles and knees are particularly affected. Chronic sarcoid of joints is rare and usually affects large joints. Sickle cell disease can present in a number of different ways. Obviously, with breakdown of cells, you get gout. You well know the association with osteomyelitis and the certain kind of osteomyelitis, but you get septic arthritis, you get bony infarction, which can be very painful. You get AVN. Often asked on boards is erythema nodosum. So if you approach the boards without knowing E. nodosum, I'm going to be very upset with you. And the infections that you want to remember are cocci, histo, blasto, the others not so common, Yersinia perhaps, as causes of E. nodosum. Crohn's and ulcerative colitis. Drugs, oral contraceptives. You probably want to remember that. And we've mentioned sarcoid as a cause of E. nodosum. They love to ask you hemochromatosis. And you can get a presentation of joints which looks like rheumatoid, particularly with involvement of the second and third MCPs. And you get chondrocalcinosis of the joint. But what you want to do is you want to aspirate a joint in such a patient. They might tell you that they're diabetic. They might tell you that they have liver enzyme abnormalities. They may even tell you that they're bronzed or deeply pigmented. And you'd be fools not to check a ferritin. Other causes of phenomenal high ferritin levels with arthritis are juvenile idiopathic arthritis or adult stills. We don't know why, but ferritin level as an acute phase protein is sometimes phenomenally high. And I know I'm running around, but I'm just trying to cover all the different angles that you might be asked. There's a sort of a weird syndrome that some people argue as to whether it's really real or whether it's just a form thrust of a rheumatic fever called post-streptococcal reactive arthritis. It tends to have a shorter latency than rheumatic fever, poor response to aspirin. There's no carditis. It's more common in adults, and there's no extra articular manifestation. But I'm always referred patients who've getting ASO titer checked for joint pain for reasons I never quite understand, but perhaps these guys have been reading this literature. We've sort of made references to pulmonary hypertension And you know that there's basically two kinds of pulmonary hypertension: primary, idiopathic, unexplained, and secondary. And there are many causes of secondary hypertension, to include fen, to include drugs, etc. But, in rheumatological situation, you're going to see it in patients with scleroderma or crest. Again, these are patients who do not have pulmonary fibrosis. They have a pulmonary arteropathy. And I do want you to know that the treatment of pulmonary hypertension is, of course, you want to give them aspirin or Coumadin. You might try iloprost, and you might try the endothelin-1 antagonist bosentan. How do you diagnose primary hypertension? Usually if pressures are above 25, greater than 30 with exercise, and you've got to exclude heart disease or other conditions, chronic thromboemboli, HIV, portal hypertension, and then cocaine and the appetite suppressant drugs are associated with this condition. Primary hypertension is a lethal condition. Most patients die within 5 years. And as I told you, we don't know that prostacycline, namely epoprostenol or bosentan, affects life. I guess a sneaky examiner might ask you, what are some of the side effects of Flolan or epoprostenol? And one of the more common ones is jaw pain, nausea, rash, headache. It's a phenomenally expensive drug. Some neoplasms that you might be asked about. There's one called pigmented villonodular synovitis, which is a patient who has knee pain usually and swelling, and it's usually one-sided. And when your arthroscopist goes in, they find this condition of pigmented villonodular synovitis. Treated with an arthroscopy. You just basically get rid of as much of the synovial tissue as you can. I don't think they're going to ask you neoplasms of joints, which are usually benign. The very rare sarcoma, and the only way that I can see them asking you a sarcoma is in a Paget's kind of situation, where the patient has obvious Paget's, and then you expected to know that there's a sarcoma like that. Glucocorticoid-induced osteoporosis, very reasonable to ask you that. It's so common. So any patient who gets more than 5 milligrams of prednisone for more than 3 months needs to get calcium, needs to get bisphosphonate in a weekly dose. And there's 2 flavors that you know. Another choice is PTH or Forteo, which can be given subcutaneously every day for 18 months, or as long as you're going to use the corticosteroids. The problem with that drug is it's expensive, but it certainly has a lot of merits. Osteonecrosis, or AVN, you can get it in trauma, connective tissue diseases, sickle cell, Gaucher's, decompression, alcohol, steroids, radiation, pregnancy, and then the most common cause, idiopathic. I think for the boards, you are expected to know that there's 6 different stages, but stage 0 and 1, which is the asymptomatic stage, is the one that you can pick up on an MRI. If they're asymptomatic, then what are you doing in MRI? And that's a good question. I don't know how you're supposed to know that. But the crescent sign is stage 3, and when you see the crescent stage, it's usually too late to do anything about it. In Baltimore, they developed, Tom Zizek and colleague, a very effective technique of core decompression, but there's only certain centers in the country that do core decompression. Most of the time, you're left to hip replacement or bone grafting. Paget's disease, another condition I'm just going to gloss over quickly. Axial skeleton may be involved, pelvis, spine, and femur. Often these patients are asymptomatic and you pick it up coincidentally, but they might present with bony deformities or back pain. They may bleed after a fracture. You well know that there's a higher incidence of sarcomas, and you treat them with bisphosphonates. And now for the final segment, what I'll just call the extremity problems. Let's talk about frozen shoulder. They love to ask a question of a patient who has profound shoulder pain, either unilaterally or bilaterally. That's a patient who cannot abduct beyond 90 degrees. And they have just what we would say is a frozen shoulder. Now, when we use the word adhesive capsulitis or frozen shoulder, what we mean by that is that if you x-ray them, you don't find any abnormalities. And what they've got usually in a board kind of question is some predisposing hint that they've got, like diabetes or myocardial infarction or breast surgery, mastectomy or reconstruction, just a clue, or even something simple like pacemaker placement, myocardial infarction, all of those predispose you to this weird condition of frozen shoulder. Your shoulder just becomes frozen. Yet on X-ray or MRI, there's nothing wrong. And the treatment is aggressive physical therapy. Very aggressive physical therapy. Some extremity problems that I want you to know about around the elbow. We've spoken about bursitis, septic bursitis, but gout can give you a bursitis. Just lifting weights can give you just a simple idiopathic olecranon bursitis, and you may be expected just to put a shot of cortisone to do that kind of patient's olecranon area. You are expected to know a little bit about medial and lateral epicondylitis. Medial and lateral. Lateral epicondylitis is usually the tennis player, but somebody's lifting weights. Perhaps they'll give you a clue that this is a patient who cannot do this, cannot pick up a heavy object or a chair or something like that. That brings out lateral epicondylitis. The treatment is injecting steroid into the point of maximal tenderness. We've spoken about wrist syndromes like carpal tunnel. De Quervain's is a tenosynovitis caused by this kind of ringing motion. And let's see if I deal with them in more details. Oh, good, I do. So shoulder problems. Adhesive capsulitis usually occurs in patients over the age of 40. I do talk a little bit about bicipital tendonitis, and they may even ask you, that's biceps head tendonitis. And a good test for bringing that out is Yergeson's sign, where you get a patient to supinate against resistance while placing your hand on the biceps groove. If the patient finds that patient painful, you've probably got bicipital tendonitis. You never know what they're going to ask you. Thoracic outlet syndrome, perhaps they may ask you that. Patient has a positive Addison test where you put some pressure on their neck and get them turned to one side, and you might increase the pain and or get them to lose their pulses. I doubt they ask you that. Back to the elbow, olecranon bursitis, lateral epicondylitis, medial epicondylitis. You can get ulnar entrapment at the elbow with numbness of the little finger and adjacent side of the fourth digit. Occupation trauma, fractures, and arthritis can cause that. But at the wrist, we have some interesting syndromes that I want to bring to your attention. Firstly, let's talk about De Quervain's tenosynovitis, which is a tendonitis of the abductor pollicis longus and the extensor pollicis brevis. And you would bring this out by asking the patient to put their thumb in their hand and abduct. And that's called a positive Finkelstein's test. Oh, wonderful. This is a good group. Another one they might ask you is the anterior interosseous nerve syndrome. And if you get these, you're just going to score incredibly highly. These are some of those esoteric ones that they're just irritating you by throwing in there somewhere. And this is a patient that cannot form an O like this. And there's no sensory involvement. And they have an anterior interosseous nerve syndrome. There's also a radial nerve palsy with a wrist drop, an acute wrist drop. Usually a drunk patient who's hanging his arm over a bench and wakes up the next morning with a complete wrist drop. There is no sensory deficit. Finally, there's a posterior interosseous nerve syndrome at the wrist, which is really a branch of the radial nerve, and these patients simply cannot extend their fingers at the MCPs. I don't think they'll ask you that, but that's just another in case one. Disorders of the hip, they always ask you that, and that's a patient who's tender on the side of their hip, and they tender over their subtrochanteric bursa. Treatment is non-steroidal, physical therapy, or inject the point of maximal tenderness with a drug like triamcinolone, about 15 to 20 milligrams. Okay, true hip pain is in the groin. I don't know, they might ask you the piriformis syndrome, which is pain over the buttocks, which you all have right now, radiating down the back of your leg, and there's sometimes tenderness over the piriformis muscle. The treatment is to inject steroids in there. I just won't do that. I think that area is too neurovascularly rich, and I think there's too many downsides to sticking a needle in there. I don't know many patients that would like me to stick a needle in their butt, not like that. Maybe you need to know about neuralgia paresthetica, which is a sort of burning, tingling of the lateral femoral cutaneous nerve. Disorders of the knee. I guess the one that they love to ask is they'll describe an obese patient who has pain 2 inches below the joint margin. Worse on climbing stairs. That is anserine bursitis. If you get that question, you thank me. Yeah. Morton's neuroma is sometimes asked. That's a patient who has an entrapment neuropathy of the interdigital nerve, usually between the third and fourth